Is Mr. Schneider. Mr. Schneider is a research professor at the Practice Center for Children and Families, McCourt School of Public Policy at Georgetown University. Most recently, he served under the Obama administration as a senior advisor at the Centers for Medicare and Medicaid Services, where he focused on program integrity issues in Medicaid. He is a graduate of Princeton University and the University of Pennsylvania Law School. Mr. Schneider.
Thank you, Chairman Johnson, Ranking Member Merkley, and members of the committee. Appreciate the opportunity to testify. So let me tell you about CCF, the Center for Children and Families. It's an independent, nonpartisan policy and research center founded in 2005 with a mission to expand and improve high-quality, affordable health care coverage for America's children and families. As part of the McCourt School of Public Policy at Georgetown University, we conduct research, develop strategies, and offer solutions to improve the health of America's children and families, particularly those with low and moderate incomes. CCF is responsible for raising external funding to conduct our work. The full list of our current funders is available on our website. CCF does not accept any government, foreign, or corporate funding. Our work is funded primarily by philanthropies. The testimony and views I'm presenting today are my own, not those of Georgetown University or the McCourt School. Here's the reality of Medicaid. It's a hugely important health insurance program for 67 million low-income Americans. It covers nearly 40% of our nation's children, nearly half of all children with special health care needs, 40% of births. It's also the largest payer for long-term care services and supports for people with disabilities and seniors, accounts for 3/5 of long-term care spending. It's particularly important to children and families in rural America and to hospitals and physicians that serve them in the communities in which they live. Non-elderly adults and children in small towns and rural areas are more likely than those living in metro areas to rely on Medicaid for their health insurance. Medicaid means access to needed health and long-term care services, as well as protection from medical debt, for children and families, and for all the other populations it serves. So it comes as no surprise that Medicaid is very popular with the American people. A January 2025 KFF tracking poll found that 77% of voters had very or somewhat favorable views about Medicaid, including 63% of Republicans and 81% of independents. In my written testimony, I discussed the role of Medicaid in our healthcare system, its importance to children and families, the harm that last year's budget reconciliation bill will do to millions of Americans who rely on Medicaid for access to health care and protection against high health care costs, and the reasons for federal and state spending, why that spending is growing. I also explained that actually reducing fraud against the Medicaid program requires collaboration between the federal government and the states, not withholding federal funds or partisan attacks. In closing, I want to sound one alarm. We at CCF closely monitor child enrollment in Medicaid. Our latest tracking, updated as of last Friday, finds that since January 2025, the number of children enrolled in Medicaid has dropped by 2.3 million. That's 2.3 million. That's as many children as in the states of Alaska, Delaware, Maine, Montana, New Hampshire, North Dakota, Rhode Island, South Dakota, Vermont, Wyoming, and the District of Columbia combined. This is a statistic that should alarm every policymaker who cares about the well-being of children. We know that declines in Medicaid coverage mean increases in the number of uninsured children. We know that uninsured children are children without access to preventive or primary care. We know that their families have no protection against medical debt if their children become sick or injured and need to go to the emergency room. At a minimum, CMS should be working with states to understand the root causes for this trend and take immediate steps to reverse it. Instead, CMS leadership seems laser focused on withholding federal funds from California and Minnesota, $2.7 billion and counting, through repeated deferrals. That is the reality of Medicaid today, and it does not have to be this way. I hope the members of this committee will work with CMS to change course. I look forward to your questions.
Thank you, Mr. Schneider. Mr. Blaze, let's quick address that issue. The 2.3 million children that have lost coverage under Medicaid. Can you explain that?
Yeah, it's a deeply misleading statistic. If you look at combined Medicaid and CHIP enrollment from before the pandemic to 2026, there's actually a higher percentage of children on Medicaid and CHIP in the first part of 2026 than before the pandemic. One of the issues is we have fewer we have fewer births in the U.S. because of the fertility decline than we have children who are moving off the Medicaid program because they age off of it. So when you account for those factors and you look at it as a percentage of all kids, there's actually a higher percentage of kids enrolled in Medicaid and CHIP than
Okay,
before
well,
the
appreciate you
pandemic.
explaining that. Mr. Schneider, there were 4 primary reforms in the first reconciliation package. The first one was requiring states to redetermine eligibility every 6 months rather than years. Do you have a real problem with that? I mean, do you want people who are ineligible to be on these programs?
I believe that the program should be only for people who are eligible.
So is there anything wrong with states redetermining eligibility? Because a lot of states obviously don't, they haven't been.
I think the state should have some flexibility in how they administer their programs. The previous
You're not answering the question. I mean, is there a problem with rechecking eligibility?
There's not a problem with
There's nothing
rechecking.
draconian about that, correct?
There's not a problem with rechecking
Okay,
eligibility.
good. Next, are provider taxes and provider fees, is that healthcare?
States are sovereign political
Is
entities.
is that healthcare?
Healthcare is a part how it gets
The answer
paid for.
is no. Mr. Blaze, so when states charge a provider fees and taxes, correct? For a Medicaid recipient, the provider gets reimbursed that amount, right? But again, the states are charging that for services across the board, correct? So isn't it true then those provider fees and taxes artificially drive up the cost of health care for people on private insurance or for people on Medicare?
They do. We actually have a study from looking at a tax that California imposed that it increased commercial prices by about 4%.
So isn't it true that you said you mentioned testimony, President Biden called that a scam. President Obama recommended doing exactly what we did in the One Big Beautiful Bill. That's not cutting and slashing Medicaid, right? That's just actually implementing what both President Biden and Obama recommended.
That's correct.
So that's the second reform, the One Big Beautiful Bill. State-directed payments, and this one is kind of baffling. Can you describe a little bit more what that is? And intergovernmental transfers, where the states plump up what they charge or reimburse, like their ambulance, their state-owned ambulance services. And can you describe that?
Yeah, so let me do state-directed payments first. On the fee-for-service side of Medicaid, there is a cap at Medicare rates. It's called an upper payment limit. That cap does not exist on the managed care side. So as states have moved Medicaid enrollees into coverage through insurers, they've realized that they can create these provider tax and financing gimmicks, get the federal funds, and then lavish much higher payments on the big hospital systems. So what the One Big Beautiful Bill did was extend the limits that were on the fee-for-service side of Medicaid to the managed care side.
So Mr. Schneider, does it make any sense to you whatsoever that for every dollar a state spends on a disabled child or blind elderly individual, they get reimbursed again in the federal match? They get reimbursed $1.33. But for every dollar a state spends on a single, childless, working age, able-bodied adult, states get $9 in reimbursement from the federal government that's $40 trillion in debt. Does that make any sense at all? That disparity to $1.33 for a disabled child, but $9 for somebody in many cases should be working? Does that make any sense to you at all?
It's a policy choice that Congress has made. There are
Again,
differentials.
that's not the question. Does it make any sense to you? It apparently didn't make any sense to President Obama because he recommended equalizing that treatment, correct?
He did. In a 2012 budget proposal called the blended rate proposal, he proposed equalizing the match rates.
Now, would he if he increased the reimbursement for